Rosalie, thank you so much for joining me.
Happy to be here.
Your research at CT Howe shows that Canada is really struggling to adopt innovation in hospitals. What do you think it is that's holding us back?
Well, partly, I'll say I went into doing that research because everybody involved in the system does want innovation to happen. They do want to improve care outcomes for patients. They do want things to be more efficient, but they all struggle and they say it doesn't happen. They run into barriers. And so I took a look at the systemic architecture where everyone's trying to make that change. And what we find is that there are so many decision makers, different institutional players with all different incentives that basically the system reinforces the status quo really strongly. And so all innovation for our hospital system kind of depends on individual champions, be that the hospital leaders, clinicians that want better for their patients. It really takes individual drive for people to innovate, and they come up against a lot of challenges. So really what my research suggests is that we need to reorient various aspects of the system to support those champions instead of putting up walls, because everyone that's working in the system truly does want to make it better.
Maybe just a quick follow-up there. How can that be achieved in terms of that systemic change? Because that is a bigger challenge.
I could go on about it probably for a couple hours, but off the top, I would say that it's about alignment of incentives and integration of different care. So we need some reason for community care to cooperate with hospitals. We need people to have access to primary care physicians so they don't end up in the ER. And, if we could take maybe the load off of the hospitals, that opens up their capacity. Because right at the moment, the biggest challenge they are facing is just a sheer lack of capacity. They don't have enough beds. If people are stacking up in the ER, that doesn't really leave any time, energy, or money to think about how you could improve care or what's next. It's really about dealing with the crisis that's happening right now. And so I think it's really about addressing community care so that we can take that pressure off hospitals so that they can then, start to have the resources and capacity to make those changes.
Let's talk a little bit further about that crisis that we are facing right now in hospitals. There's a term that is new to me, which is the ALC crisis. The alternate level care patients are occupying more hospital beds, and this is having an impact on the capacity of our hospitals. How big of a problem is this?
Alternate level care patients are people that, they do need healthcare, but they would be better served outside of hospitals. And generally their outcomes are actually better if they're treated outside hospitals. So you're thinking about seniors that might need ongoing care and there's just no LTC bed available, or just really people recovering from surgery and there's just no home care for them to go home. And so people occupy these beds, and then that creates a domino effect where someone shows up at the ER, there might not be a free bed to admit them to. And the size of the problem is substantial. ALC bed days take up more capacity than all of the top 10 surgeries combined in the country. And it's about 1 in 5 days, a little bit less or a little bit more, depending on what province. But fully a large chunk is dedicated towards caring for people that shouldn't be in the hospital and actually would likely rather be elsewhere. And this is really the worst outcome. It's the worst outcome for the hospital. It's the worst outcome for the patient. And it's the worst outcome for taxpayer dollars because the hospital is the most expensive place for them to be. So really it's a no-win situation. And I consider it the biggest challenge that our hospitals face.
Just to echo that, I mean, it does seem like it is a massive challenge, one that's going to be a little bit more difficult to solve. But one of the areas where I think we have the biggest opportunity is with our health records. And this always kind of blows me away because in this digital age, it's still not easy for Canadians to access health records. And it is different in every province. So I do want to say that, but certainly as someone who's here in Ontario, in some cases you have access to health records, but in my birthplace of Prince Edward Island, they're still dealing with a lot of paper and faxing. And so it feels like this is low-hanging fruit. Why is this such a big problem in this age of technology where all of this could be easily streamlined?
I would totally agree. If we had integrated data between care providers, it would make things so much easier for physicians as well. Patients wouldn't have to repeat their medical histories. All of this would save time, administrative work. And also I would point out that it's incredibly important for Indigenous communities and Northern communities, especially the territories, where those patients get flown to other provinces, but we might not have the mechanisms to share digital records, even amongst their care providers, let alone the patient themselves having access. And so I think partly it empowers patients to be able to have access to that information. They feel more able to manage their own care. But even at a systemic level of just care quality, we don't have the right integration. And I think that is directly on government, because there's no incentive for your primary care physician to link in with the hospital. And actually, in a lot of cases, it's a risk-averse culture. The law would allow these things, especially with patient permission, but because there's this culture around keeping patient data private, and really just being good data stewards, we haven't moved forward on a lot of this data integration, despite, I would say, lots of government funding over many, many years. And so at that point, we get back to the systemic challenge. What's the incentive? The hospital is busy. Do they actually have the time, energy, change management resources, IT expertise in-house to actually build these systems? So at some point, the government needs to put the infusion of cash there, but also provide the guidance and force a certain amount of harmonization, because everyone wants to use the system they've got. And so they want everyone else to adopt their system, as opposed to everyone moves to one harmonized integrated system. So how we do that, through data standards or linkages or regulated a system, I do think it is directly the role of government to start addressing that problem.
I feel like it might even be a bigger problem than we have data for, because there's a lot that gets missed in not having these health records in a digital format, right? Because I've heard stories, some within my own family, where, data points were missed, but blood work, nobody had their eyes on it, right? So a lot of lives can be saved in this process as well.
Yeah, and we can do earlier detection. The more information you have, say someone is at risk of developing heart disease or kidney disease in the future. If you see that earlier in their data, you might be able to intervene, get them the tests they need to determine if they're at risk long before they would ever have symptoms. So there's a huge aspect of preventative healthcare to it. And I would also just add that if you've done a diagnostic test once and then you go to another doctor, do you really want to get that blood draw done again? If you just had the test results, or the doctors could just share them, patients also wouldn't need to redo things. And that's also a big draw on the system. When we lack capacity, having to redo things or have doctors spend time calling each other trying to get these records is truly just an inefficient waste of time, and also something the doctors hate doing. One of the biggest complaints is how much time they have to spend on administration. And for family doctors, dealing with referrals to specialists for their patients and following up on those is a good chunk of their time. When we're struggling with access, having this digital foundation could improve patient care, number one, but also free up a ton of physician time. And I think that is something that we need to remember, because we do have an access challenge for primary care. And if we can just save each physician an hour, that's probably a faster way to address the problem than taking kids all the way through medical school. That takes many, many years, and we have the problem today.
If we act now, and if we are aggressive in terms of some of this systemic change that needs to happen, what is possible for Canadians, and who's responsible for all of this?
Well, therein lies the challenge, right? Is who is responsible? And in the current system, the somewhat upsetting answer is kind of no one. Arguably the health minister, but the health minister doesn't necessarily control various aspects of this. And I should say, I mean that provincially, because the federal health minister, constitutionally, they don't get to administer the healthcare system. So the buck stops with the health minister. But when you really think about what their job is, there's delivery on existing programs. Most of the budget is already spent. And they have to sort of manage the problems as they arise and might want to do new programs. So their job isn't directly improving the existing system for patients. Is it the hospital CEOs? They have to keep the hospital solvent and running, and that's a full-time job. On and on and on. You could go through each of the different institutional players, and essentially nobody has a direct incentive to improve care for patients. The fact that care has improved at all, actually, I think is a testament to the champions in the healthcare system, because from a systemic perspective, there's very little that actually supports change or improvement or doing things, particularly doing things that don't fit in the current pathways or the current ways of evaluating things. I think we might be able to go further if at the government level, at the provincial government level, we had someone that was their job. Their entire job was to improve things for patients. And until that exists, I think these systemic conversations about change will always be a bit of an afterthought. We can't let perfect be the enemy of the good, but whatever is the most urgent is the most important. And that's not necessarily true, but everything in healthcare is urgent and everything is important. So if it's something that's second order, we just never get to it. And so I think we need to build that capacity, and we need to empower those leaders, because it's possible. We can all see it, and we could all have a better system. It could be cheaper, more convenient to access. All of this is very much possible. But no one has the incentive or the sustained resource capacity to actually do it. And so that's where the government comes in.
Certainly, we're only scraping the surface on this topic. It is a big one. For people who are interested in reading more about your research at CD Howe, where's the best place for them to go?
Well, I mean, please come to our website, cdhowe.org, and follow us, our YouTube channels, our social media. We've got it out there. I mean, we are a bunch of economics nerds at the end of the day, but we do actually, put it out there, and we're on social media as well. But the core content, those 30-page technical papers, they're on our website, or, email me. I'm happy to send it over.
Excellent. Thank you so much, Rosalie.
Thank you. Happy to chat anytime.